Our first abstract for this session is entitled Same-Day Discharge After Appendectomy for Children with Simple Appendicitis, a Quality Improvement Project, presented by Dr. Juviler from University of Rochester.
Thank you. Good morning, everyone. Here are our authors. We have no disclosures. So same-day discharge following appendectomy for simple appendicitis has been shown to be safe, effective, and associated with parent satisfaction. Our aim was to improve same-day discharge following appendectomy for simple appendicitis by 25% in 1 year. To do this, we created a primary driver diagram and identified 2 drivers: variable postoperative care and operating room access. We use these drivers to produce change ideas, and I'd like to talk about 3 of these today. First, standardized postoperative guideline, which I'll talk about on the next slide. Next, a surgeon of the week model, where we have 1 surgeon with their primary focus on the service with minimal outside interruptions, for example, avoiding clinic that week. And finally, urgent operating room, which consisted of 1 OR, left open to prioritize overnight cases instead of trying to fit them in with the existing schedule. Here's our guideline. It created a consensus for discharge goals amongst all members and family. It included avoiding routine prescription of antibiotics and narcotics. Our hope was that this created milestones for discharge no matter the length of time following the procedure. So once a patient taught a regular diet, ambulated, and their pain was controlled with oral medications and there are no other concerns, they were discharged. In terms of our methods, we collected our data prospectively, starting January 2018 to September 2019, and that was the pre-implementation. Following that, we collected data up through June 2021, and there was about 270 children in each group. In terms of outcome, our primary result, patients discharged day of surgery increased from 32% to 75%. Time to OR did increase about 90 minutes. However, total time in hospital from ED presentation to discharge was reduced by 8 hours. Here you can see our run chart. This demonstrates the percent of patients discharged same day by month. The blue line is representing the percentage of patients discharged, with this orange line representing the median percent. You can see our clinical practice guideline was introduced in September 2019, followed by the surgeon of the week and urgent operating room models. And there is a clear shift in the median around this time of implementation. Additional results, our process measure fewer children were discharged home on oral antibiotics, and there was no change in balancing measures, including return to ED, readmission, surgical site infection, and percent opioids prescribed. For our value, in the first 21 months, there were 140 hospital days saved, and we estimate that this saved our system about $220,000. Our QI process included a multidisciplinary team that had attending surgeons, an ID attending, QI specialist, APP, and a resident, which is all vital to buy-in. We also had regularly scheduled meetings to keep the project current. We did calculate the monetary value with days saved, but there's also the opportunity of open hospital beds in our hospital, which is often over 100% capacity, and this is harder to quantify. We perpetuated antibiotic stewardship as incorporated into our guideline as a balancing measure, as well as reinforcing the national guidelines previously established. And finally, the drawback to QI is that we implemented all of these changes at the same time, so it's difficult to attribute any of our results to one of these interventions individually. So to conclude with this QI methodology, we're able to increase rate of same-day discharge, decreased total time in hospital. We decreased oral antibiotic use. There was no difference in balancing measures, and we added value to our hospital system and families. Thank you.
This abstract is now open for questions.
Fantastic presentation, and I think a lot of us are trying to move towards the same-day discharge. Now, you mentioned your value added that you saved, based on this many hospital days you've saved the institution $240,000. But for me, the hardest part at any hospital is getting them to agree to keep an OR open for urgent cases, and especially at smaller institutions like U of R and mine. That's expensive, and I'm guessing it wasn't in your value added. Do you know how much it would have cost the institution to have that OR kept open, and how much pushback did you get trying to say we want to reserve an urgent OR for our peds cases?
Yeah, I think part of the bargaining with that is that we shared it with the orthopedic service, so that kind of made it easier to keep it open. So it was being used a lot of the time. It wasn't usually just an open, empty room. So that helped with the cost portion. Yeah. Thank you.
Andreas Mayasuni, Upstate, not too far away from your institution, by the way. Question for you. Your data collection ended in June of 21. Since then, we at least have had major manpower issues. Have you seen a decline in your data since then? Have you had less success with same-day discharge? Because we have a really hard time keeping ORs open at this point.
Mm-hmm. We haven't done a full analysis of the data after that point, but that'll be interesting to see how that's affected it from then until now with those changes. So, yeah, thanks.
Hi, Diana Deason from UT Southwestern in Dallas. I applaud your work. We did something similar a few years ago and found that we've been able to discharge somewhere around 70 to 80% of our patients with uncomplicated appendicitis same day with good patient satisfaction. A question for you is what is your routine after the case? Are they discharged from PACU versus the floor? We had found discharging from PACU is more successful, and sometimes on the floor things slowed down a little bit. So I was wondering what your experience was.
Mm-hmm. Often these patients go right from the emergency department to PACU, and I think that definitely streamlines the process because all of the nurses in PACU are on board with this goal. So I think majority of them are from PACU. Yeah. Thanks.
Stoller, Santa Barbara. I'm curious, because you saved the hospital $240,000, how they shared that with you. It's a serious question.
How they shared that savings, you're saying?
Yes.
That's a question for Dr. Wakeman, I think.
PayPal.
Thanks.
Barb Gaines from Pittsburgh. I applaud your work. Our little tweak to this is that we give the patients a conditional discharge in their post-op orders so that if they meet the criteria, they are discharged and not waiting for someone to write the discharge order. But I was wondering when we have placed an urgent room, the initial reason for it was things like appendectomies, but other people use it. And I was just wondering if you're tracking your utilization of that urgent OR, because I suspect that it's not just being used for your cases, but it actually has increased efficiency of your OR in general.
I see. Yep, I think that would be a good thing to do on a more systems level for the whole surgery team in the pediatric hospital, so we can also look into that too. Thanks.
We have one virtual question.
The virtual question from Dr. Faroki. How many times does families call back within 24 hours from discharge with a question or concern?
I don't know the exact numbers, but I don't think it's very often. And if there is an issue, we would send them to the emergency room just to be evaluated to be safe. So.